Now, in MDS, we have what's called clonal hematopoiesis. And what that means, we have many clones of these stem cells, but one doesn't outgrow the other. But for whatever reason, the acquisition of specific mutations at the DNA level of a hematopoietic stem cell may give it a selective growth advantage. And so, it's a clone that expands at the expense of the other hematopoietic stem cells. And what's kind of a paradox is that even though it has a survival advantage and can kind of choke out the other hematopoietic stem cells, at the earliest stages, it actually has, it's defective. And as a result of it growing out, the progeny are defective, and there is excessive cell death in the bone marrow. So the blood it's supposed to be making, the terminal blood cells that are supposed to be made, your red cells, your white cells, your platelets, they're not being made. And that's why the disease presents with low blood counts. So it has a selective advantage to kind of take over the bone marrow, but paradoxically make the bone marrow fail. And, MDS is not one disease. So, we start with a normal stem cell, then there's a founding mutation, often in a pathway, a very common pathways, one of two pathways that affect how RNA is spliced or how the DNA is methylated. Now, that's not usually enough to form the disease. It just gives it a selective growth advantage. We'll talk about that as well, about CHIP. But over time, as these cells expand, and it's under the influence of many things, genetics, environment, obesity, smoking, lifestyle, we don't know, pesticides for all we know, it expands and acquires more mutations. And mutations beget mutations. And we call that clonal instability. So over time, that original kind of innocuous clone that just sort of hung out a little bit more, was making up maybe 4% of your bone marrow, starts to expand and acquire more and more mutations. And in the terminal part of things, you either have complete bone marrow failure, or in the worst case scenario, you develop acute myeloid leukemia. But within any given patient who has myelodysplastic syndrome, we're not dealing with one clone. You can say that about all cancers. There's always branching off clones. Some have more selective advantages over others with regards to their growth. But when we're targeting the disease, sometimes we can eradicate some clones, but we can't eradicate the others. And then those are the ones that come back and cause the relapses. Now, I'm talking about mutations a lot, and I'm not trying to have you learn all these mutations. I don't even know all these mutations and exactly what they do, but they can kind of be lumped into what their normal counterparts would be regulating in a cell, whether or not it's cell division. Oh, thank you. Cell division, how the RNA is spliced, tumor suppressor genes that sort of are supposed to shut down the cell if it's becoming too malignant, and so forth. And we know that these mutations occur in a specific order. So we can kind of identify when somebody has, for example, a RAS mutation, which is sort of right at the very end over here, we know that this is sort of in a late form of MDS. Whereas the spliceosome mutations are in early forms of MDS, and they have prognostic value. And we'll come to that and why they're so important from a prognostic point of view. Now, having a mutation does not equal MDS. In fact, we now know that 10% of the population over the age of 70, and it's probably even higher now if you use more sensitive techniques to detect them, have these mutations, the same mutations, especially the early mutations that cause MDS, that lead to that clonal dominance, can be detected in normal, healthy people. And we call that CHIP. The acronym is clonal hematopoiesis of indeterminate potential. And this is old data now. You can see this was initially published in 2014. They used a huge database of from the UK of healthy people that were followed over time for linkage between genes and diseases. And what they found was that 10% above the age of 70 harbor these mutations. And you can see how it increases dramatically with age. And it may just be intrinsic to our genome that mistakes are going to happen. We're intrinsically destined to have mistakes happen at the DNA level. Now, some of them, it doesn't matter. These mutations are innocuous. They have no consequences, but in other cases, they do have consequences. And then they set in motion many, many other mutations that culminate in the disease. So some patients in my practice we think they have MDS, but we can't prove it. And in order to make the diagnosis, you have to fulfill certain criteria. So at the earliest phase, we think of CHIP as being the first founding thing that can lead to MDS, but the risk of that is probably 0.5 to 1% per year. If you have low blood counts, but have no mutations detectable in your blood or bone marrow, we call that ICUS, which is idiopathic low blood counts, cytopenias. We don't know what that means. And some of those patients will go on to develop mutations. So sometimes we'll follow them along. The blood counts will get worse. We'll repeat their bone marrow. And suddenly we find mutations that they didn't have. We'll see dysplasia in their bone marrow that they didn't have. So some patients with ICUS will go on to develop MDS. And some patients will go on to MDS, but that's at a low rate. Once you start having low blood counts and mutations, we call that CCUS. And we have patients like that, and some of you have been labeled as CCUS. We are more worried that you're on that trajectory to developing MDS. But we now know that some CCUS is really low risk of going on to MDS, whereas others are not. And we have calculators that we use that can predict that. And in the terminal part of things, and that rate is, again, more like 20 to 60% risk for CCUS to going on to MDS under the influence of just time. And again, these other factors that we don't completely understand, but inactivity, smoking, obesity, genetic predisposition, we don't know. Some patients will go on to develop MDS and even AML. So we, in my clinic, if somebody comes and they have low blood counts, we've done their bone marrow, we find mutations, and we then want to figure out, but they don't have the necessary abnormalities in their bone marrow that fulfill a diagnosis of MDS. It looks pretty healthy. The bone marrow looks minimally abnormal. It doesn't meet the 10% cutoff of abnormality. We call that CCUS. And then in order to determine how likely is my patient with CCUS to go on to develop MDS, we apply one of two calculators that are available that pays attention to their age, the size of their red cells, how many mutations, how frequent these mutations, what kind of mutations. And then you plug it into this calculator, and it essentially divides patients into 3 risk groups. So obviously the one that we're most worried about is the high risk group. And there's some recent evidence from colleagues of mine down at the Moffitt that would suggest that someone who has a high risk score is basically just an early form of MDS. They behave exactly the same, and that we should be treating them as such. Because they eventually do go on. You can see, if there's no plateau, it basically goes up to 100%, but it could take 12 years till that happened. And so it doesn't necessarily mean that they need treatment. But if they have very low blood counts, we should probably be including them in some of our clinical trials that are targeting these low blood counts, like transfusion dependent anemia, if they have high risk scores. So how do patients with MDS present? There's 2 scenarios. One is somebody shows up for a hip replacement surgery. They have blood work. They haven't seen their GP in a number of years. They stopped seeing their GP over the pandemic, and they just haven't gone back. So there's nothing in the system for 3, 4, 5 years. and then they have their blood work before their surgery and they find them to be anemic or have a low platelet count or a low white blood cell count. They get referred to a hematologist, and a bone marrow is done and the diagnosis is made, so asymptomatically. And then the other presentation would be somebody's presenting with decreased exercise tolerance, shortness of breath on exertion, fatigue, fatigue that they just can't explain, bruising, easy bruisability, or rarely, but it's definitely, sometimes a way of presenting would be recurrent bacterial infections. To make the diagnosis, you need the following. You need at least one reduced blood count and one of the following. So either dysplasia, and this is what the pathologist will look at under the microscope to see how much does that cell line deviate from normal. And the cutoff is 10%. So 10% of your red cell producing machinery has to look dysplastic, or your platelet machinery has to look dysplastic, and so forth. If you have too many immature cells, and those are called leukemia blasts, normal would be less than 2%, but basically a cutoff of 5% or higher defines you as excess blasts. That would make the diagnosis. And then having an MDS defining chromosome abnormality or genetic abnormality. And that's picked up with our genetic testing, which we'll get to. Now, what's the problem with having MDS? We know that patients with MDS, even if they don't go on to develop leukemia, and only 20-25% do, at least from the National Registry, what's the problem with the disease is the disease curtails it reduces your quality of life, and it reduces your expected survival because of complications of bone marrow failure. So low blood counts lead to red blood cell, anemia leads to decreased oxygen carrying capacity and decreased exercise tolerance and dependence on red cell transfusions that can lead to iron overload. Iron overload can cause organ problems. Patients, even when their platelets, let's say, reduced but not too reduced, they're still at risk for bleeding because the platelets don't function as well and the white blood cells don't function as well. So there's a higher rate of infections. And then we also know, and we've learned in the last decade or so, that heart disease, cardiovascular disease, coronary disease, strokes is more prevalent in patients with myelodysplastic syndrome, even compared to age-matched controls. So you take somebody the same age, the same weight, the same background, who does or does not have MDS, the patient with MDS has almost a 25% to 40% higher risk of having cardiovascular disease. And we now understand what the mechanism is. The same blood cells that are circulating with these mutations are pro-inflammatory. These white blood cells are pro-inflammatory, and they promote the development of plaque in your coronaries and in your aortas and so forth. And so that is what we believe is the mechanism for why patients who have MDS, who have clonal hematopoiesis, and by the way, this is also seen for CHIP, that they are higher rate of developing coronary disease. There's very complicated risk classifications that we have. There's two warring ones going on right now. They're trying to harmonize them. But conceptually, we can think of, and I always like to sort of pare things down into smaller numbers. We can think of MDS as chronic phase, accelerated phase, and the terminal kind, which is MDS and AML. And so in the chronic phase, we have three entities. They're listed on the slide. I don't have to say them, but essentially, if you don't have excess blasts, if you harbor a favorable mutation affecting a gene called SF3 beta 1, or if you're in the 5% of patients that's called MDS with deletion 5q, meaning the long arm of chromosome 5 is missing a piece, you're considered favorable and chronic phase. The accelerated phase is already when you've already started to acquire mutations, or you've started to get mutations or loss in a critical tumor suppressor gene called TP53. And we also know that patients who have scarring in their bone marrow seem to behave more aggressively. We don't understand why. And then if you're starting to get into 10 or more percentage of leukemia cells, some hematologists actually consider that tantamount to as bad as having acute myeloid leukemia. But in our current classification, we consider that still MDS. We have a number of prognostic scoring systems that we use in the clinic. It's evolved from 2 decades ago, more than 2 decades ago, called the International Prognostic Scoring System. Then it was revised, and now we have one that's molecularly based. They all require online calculators, but they basically attach weight to what your blood counts are, how reduced are they, what the chromosome abnormalities are, and how many immature cells, how many blasts are in your bone marrow. So there's weight assigned to all of those, and it essentially dichotomizes you into, in the IPSS, 4 risk groups, and the IPSS-R 5 risk groups, and the IPSS-M 6 risk groups. But again, I'm going to show you how conceptually hematologists divide people into 2 risk groups, low risk and high risk. One of the biggest innovations in the field of hematology has been in our techniques to identify at a very granular level what is wrong with the DNA. And there's this technique called next generation sequencing. It's probably been available around the world in many wealthy centers for over 10 years. And so a lot of my colleagues who reside in the United States or in Germany or in Italy, they've had this technique available to them, or at least paid for. It's not that the technique didn't exist. Our scientists, our labs had it available, but in terms of routine clinical care, it's only been funded, what would you say, James, in the last 3-4 years in Ontario, and probably most of Canada. So our ability to refine the prognosis of somebody looking at their mutations has been available to us just in Toronto, and for sure at Sunnybrook, in the last 4 years. And it's a more sensitive way of diving into the DNA. And we also have improved techniques to identify at a larger level what chromosomes are missing or deleted or exchange of material. And that also has prognostic value in our risk calculators. So the most current technique called optical genome mapping, that I can't even begin to explain to you, even though I've read about it and had scientists explain it to me as much as possible, actually is a very, very sensitive way of detecting chromosome abnormalities. So if a resident's in my clinic and they're seeing a new patient, my expectation is after they've seen the patient is that they're going to go online and they're going to plug in all the numbers of the MDS patient who's like a new patient. They just had their bone marrow. They're coming for an assessment to plug in and determine what their risk score is. So the IPSS-R that looks at 31 genes, the low blood counts, the depth of the low blood counts, the chromosomes, and so forth, will plug all their numbers in. And for example, here's an example where the patient has in the calculator actually comes up with this exact printout, and it tells me my patient has a very low risk score using the IPSS-M, a very low risk score using the IPSS-R, and what the leukemia-free survival is, and the overall survival is, and the risk of transformation to acute leukemia at 1 year. And then it shows me a graph of where my patient falls with regards to the 6 risk calculators, the 6 risk groups. But essentially, we think about patients as low risk and high risk. So the lowest 3 of the IPSS-M, which would be very low, low, and moderate low, our approach to therapy is different than patients that are considered higher risk, which are in the top 3. And that's because, as you can see, there's progressive decrement in projected survival as the risk group goes up, and an increase in the risk of leukemia as the risk group goes up. So our approach in lower risk patients is to try to reduce the dependence on transfusions, avoid transfusions, improve the platelet count if the patient is symptomatic, improve the white blood cell count if they're symptomatic. And we have a number of agents available to us to do that. Erythropoietic stimulating agents, EPREX, or darbepoetin, which is Aranesp, luspatercept, which I'm going to talk about. Sometimes we'll offer chemotherapy for someone who's considered lower risk, but who has symptomatically low blood counts. And in some instances, it's appropriate just to watch and wait. When the blood counts are really minimally reduced, the patient has no symptoms, we can just watch and wait. In higher risk patients, we're then more geared at maybe extending survival. And in the case of somebody who's below the age of 70, 75, for example, who's well and healthy and robust, we might think about allogeneic stem cell transplant, which can replace the damaged bone marrow. And in cases where that's not appropriate, we have at our armamentarium a selected chemotherapy that's approved specifically for MDS in a class of drugs called hypomethylating agents, and we have two, and I'll talk about those as well. And in all cases, our goal is not only just to remedy the reduced blood counts and avoid transfusion dependence or reverse transfusion dependence, it's to also improve quality of life. Right? Because we know these low blood counts impact quality of life. That's some of my research from the registry that we've learned. And in all cases, we are trying to improve that. Now, this is the depressing part about MDS. If I were to show you this for acute myeloid leukemia, there's bars left, right, and center, up and down for all the drugs that have been approved in the last decade for acute myeloid leukemia. And it's not for lack of trying, because I'll show you there's been a lot of efforts to try to improve outcome. It's just that the trials have failed. But what you can see is that, we got our first hypomethylating agent drug, azacitidine, was approved in 2004. Lenalidomide and an iron chelator, an oral iron chelator, was approved in 2005. And then a cousin of the drug azacitidine was approved in 2006, and that's for lower risk disease. And then for higher risk disease, azacitidine was approved because of a landmark study that showed a survival benefit to azacitidine. And then there's a 10-year gap till we start having approval in Canada. Cindy's like nodding her head here. She's been an advocate for these drugs, of approval in Canada of decitabine, and then the oral version of decitabine, which happened in 2020, and finally in 2021, luspatercept. So really kind of a paucity of therapies in myelodysplastic syndrome. And it's probably a variety of things. First of all, pharma only started becoming interested recently. 1, 2, it's a tough disease to treat because it's a stem cell disorder, and patients are about a decade older than acute leukemia. And so you have all the other health problems go along with that. It's a more challenging population to treat. And 3, many trials that were tried were unsuccessful. So, and I'll allude to that in a second. So here's our current treatment algorithm. We, again, dichotomize patients into lower and higher risk. We decide, do you need treatment or not? And if you do need treatment, and that would be usually somebody who's symptomatically anemic or transfusion dependent, we then decide, okay, what do we have to offer you? If you're in the 5% of patients that has what we call deletion 5q, that critical commonly deleted region of the long arm of chromosome 5, you're lucky that we have a targeted agent for that disease called lenalidomide, a common drug that's used in myeloma, as it turns out, is actually very successful for deletion 5q. But if you don't, and that's 95% of patients with MDS, then we have to decide on what can we do to get your blood counts up. If you're anemic and you're your own erythropoietin production is not keeping up, we can give you erythropoietin. And if you're heavily transfusion dependent, we'll try to stave off the consequences of the iron overload that you get from the red cell transfusions with chelators. And we have a number, but we have a number of oral ones, and we have one that's given is an injection under skin, deferoxamine. And then if you are a patient, about 20% of our MDS patients will fall into a classification called MDS with ring sideroblasts. You'll remember in the chronic phase, there was the patient that has a mutation affecting a gene called SF3 beta 1. They often go together. We have the approval of the drug luspatercept, and we would use that if the erythropoietin didn't work or if it worked and stopped working. And for everybody else, so the 80% of the other patients or 75% of the other patients, if the erythropoietin stops working, we have options such as lenalidomide, which sometimes works even if you don't have deletion 5q, but is not currently funded by the Ministry of Health, unfortunately. If you have insurance or if you can get it compassionately, we would sometimes try it. Clinical trials are always an important thing to consider. And then, as I mentioned, the drug that's often used to treat higher risk disease, azacitidine or decitabine, has activity in lower risk disease. We just don't know that it improves your survival, but it can engender or allow patients who are requiring red cell transfusions to get off of transfusions about 45% of the time for a period of time. If you're higher risk disease, and by the way, the breakdown is probably about 65%, at least in Canada, in our registry, about 65% are low risk and 35 to 40% are high risk. We have to decide transplant eligible, yes, no. And to be transplant eligible, number one, you can't be too old because they do have cutoffs. 2, you can't be too frail because it's a really rigorous thing to go through. And 3, you have to have a donor. Now today, because we can use siblings, we can use children that are even just a 50% match, that's much less of a restriction. So finding a donor is not as difficult, but historically it was only 25% of your siblings were matches before when we required full matches. But in terms of the actual percentage of patients with MDS that go on to transplant, it's probably 10%. And it's mainly because of age. You know, our patients are in their late 70s or 80s or even 90s sometimes. And so transplant is not a possibility. So in the case of higher risk disease, then we have at our armamentarium hypomethylating agents, either azacitidine or decitabine. And numerous efforts to improve on the outcome of that have been tried. That's where most of the focus of research has been. And unfortunately, and I'll show you a slide, they've all been negative. So let's talk about luspatercept. So luspatercept is kind of a new kid on the block for us in the last few years. It is not erythropoietin. Erythropoietin works early in red cell production in the factory of our bone marrow, and luspatercept works late. We call it a maturation agent. And what it does is it acts as a blocker of the blocker. So in MDS, it turns out there's proteins that are leading to a maturation arrest. Instead of the normal differentiation to happen where you end up with a red blood cell, there's a blockage in that. And so it overcomes that blockade by binding up the bad proteins that are causing that. We call those TGF-beta ligands. It binds those ligands and prevents that maturation blockade. And that's a picture of what a ring sideroblast looks under the microscope. You do an iron stain, and it looks like there's a ring of iron around the nucleus of the red blood cell in an immature red blood cell. And again, about 20% of our patients fall into this category. So luspatercept is an option if you had erythropoietin, it didn't work, or it worked and it stopped working and you are now dependent on transfusions. And that's based on the results of something called the Medalist study. It was basically targeting exactly that patient population. And you can see that achieving 8 weeks of transfusion independence was possible in 38% who got luspa versus 13% got placebo. In terms of durability, let's say lasting 3 months or more, that was achieved in 33%. And the longest period of remaining transfusion independent was 31 weeks. But what they were seeing in the study is that some patients were maintaining long periods of transfusion independence, let's say 3 months, whereas they were getting them like clockwork, 2 units every 2 weeks, month in, month out, month in, month out. Then they would go 3 months without a transfusion. And for some reason, their blood counts would drop and they would require transfusion, but then they'd go another 4 months, for example, without transfusions. And so when you summed up how many units of blood they got in a year on the study versus before, there was a greater than 50% reduction in their transfusion needs. And so even if it didn't make you completely transfusion independent, it still reduced your dependence a lot. And so by virtue of that drug got approved. The pharma company that manufactures luspatercept, BMS, then tested it in earlier disease in a head-to-head comparison against erythropoietin. And across the board, it was a better drug. And higher, you can see response rates are higher, more like 60%, 66%, and particularly active again in this patient population that has ring sideroblasts. In this study, they included all comers. So it's definitely more effective in patients who have ring sideroblasts. And in comparison to erythropoietin, in those who don't have ring sideroblasts, it's about the same in activity, but it lasts longer. So it's a more durable drug to use. Unfortunately, it's not yet approved as frontline use in patients with ring sideroblasts who are red cell transfusion dependent in Canada. And I don't know what the company's strategy is to try to counteract that. I believe they're trying to get that approved, but because it's much more expensive than erythropoietin and it's not yet generic, we don't have that available to us. So it's only available to us second line or in the context of a clinical trial. And this just shows you how much longer it works in terms of lasting more than 12 weeks. A higher percentage of patients got that with EPREX, with luspa over EPREX, maintaining transfusion independence for a year, 44% with luspa versus 27% with EPREX, and more than 1.5 years higher as well. And if you add up all the period of time of transfusion independence with luspatercept compared to erythropoietin, it's longer. Another new development is dosing is important. So the way luspatercept is dosed, I don't know if anyone here in the audience has had luspatercept or is tried it, is you're supposed to start at a low dose, give it 6 weeks, go up to the next medium dose, give that 6 weeks, and go up to the highest dose. And what it turned out is a lot of patients were falling off before they even got to the highest dose. And so this isn't yet published, but there's a study called the Maxilis study where they took patients who either had never had a luspatercept or had erythropoietin and it wasn't working for them. And they were started on the drug at maximal dose, 1.75 milligrams per kilo. And results are much more impressive than the previous results when using the dose escalation phase. So in terms of patients who had never had erythropoietin, 81% of patients got off of transfusions, and a good number of them maintained that for 3 months, 75%. In those who had previously had erythropoietin and then got luspatercept, it's not as high, but you can still see really respectable response rates. Instead of the 20% that we saw with the Medalist study of 12 weeks or more, 23%, it's 50%. So the message is, and I've been sort of spreading the word to my colleagues, and this is how I operate in my practice, is I start with higher doses from the get-go. And it's also partly because the government gives us 6 months to prove response, or they don't provide funding for it. So it's better to start higher, and you can always dose de-escalate if you need to, but try to prove response early. And so if somebody is not requiring a lot of transfusions, I'll start at a medium dose, and after 3 weeks, go up to the higher dose. But if somebody is very heavily transfusion dependent, they're getting 4 units a month, I start immediately at the 1.75 milligram. And so that's something you as patients should know about. Another development in lower risk disease is this drug that targets telomerase. Telomeres are the analogous, and I make this analogy in my clinic to patients, are like those little plastic things at the end of your shoelaces that keep them from unraveling. Because when that plastic thing falls off, your whole shoelace gets frayed, right? So imagine your chromosome fraying, the double strands that are wrapped together, they fray. And that leads to cell death when that happens. And we have enzymes in our cells called telomerases that maintain the integrity of our telomeres. Every time a cell divides, your telomere shortens a little bit. And cancer cells, because they're dividing faster than normal cells, they have upregulation of the enzyme telomerase. That helps them maintain the integrity of their telomeres so that the cells don't die. And so what these really smart scientists did is like, okay, let's try to target telomerase and block it and get rid of the selective growth advantage that our cancer cells have. And so that's what telomerase, what this drug imetelstat is. And this is approved for use in the MDS space for lower risk disease in a similar patient population to that of luspatercept, but for all comers, not just for patients who have ring sideroblasts. It's an intravenous drug. The randomized study was called the iMERGE study. It just got published a couple of years ago. And essentially, they randomized patients who were requiring transfusions, heavy need for transfusions, and randomized them to placebo or imetelstat and evaluated them for impact on their transfusion needs. Now, compared to the luspatercept population, these patients were much more transfusion dependent. Luspatercept, on average, it was 2 units a month. These patients were 4 units per month. And they saw a significant improvement in transfusion independence that was very durable. So yes, only about 40% of patients responded, but of those that responded, many of them had sustained response durations, often more than a year. And it worked in all forms, not just the patients who have ring sideroblasts. And because it targets the dividing cancer cell, they actually saw a decline in the cancer burden of the cell. So when they looked at the mutations that the patient had, the frequency went down. So it's actually having anti-clonal activity, which none of our drugs in low-risk MDS do so far. So for higher risk disease, I mentioned the class of drugs called hypomethylating agents. We have 2, azacitidine and decitabine. Decitabine, which is initially IV, we now know can be given orally as long as it's paired with a specific enzyme that prolongs its survival in your circulation. They're not identical drugs. They both work to decrease the abnormal methylation of your DNA. Methylation leads to shutting off of the gene from being expressed, and cancer cells have too much methylation. But one works more at the protein level, one works more at the DNA level, but in the end, they do lead to DNA damage. So they're what we call cytotoxic. They kill cells by damaging their DNA. In the case of azacitidine, it also damages the RNA, which is necessary for making protein. So that leads to cell death. And more importantly, the elegant part of them, because we have lots of cancer drugs that are cytotoxic, is they turn on gene expression of genes that have been abnormally silenced and by methylation. And as a result of restoring the normal expression of the genetic material, the cell can then mature, or it can express proteins that allow the immune system to recognize it as a cancer cell and attack it. And so that's how we believe hypomethylating agents work. And we really only have one randomized study that was published many years ago called the AZA-001 study that was compared to conventional care in higher risk disease and showed that azacitidine significantly reduced the risk of leukemia and prolonged the survival by 8 months, but was not a curative treatment. And so all these efforts have then been expended to try to marry another drug with the backbone azacitidine over the last decade against azacitidine alone in the higher risk space. And unfortunately, they were very promising in phase 2, but unfortunately in the phase 3 study, they did not meet their primary endpoint, whether or not it was higher complete remission rates or survival and so forth. And the message is that you can't make changes to our management from just phase 2 studies. In a phase 2 study, everybody gets the drug. And it looks great compared to what you used to expect. It looks, oh, this is the best thing ever. This is going to be that's why they do the phase 3 study. Let's prove it's better, and it's now going to replace the old. But in multiple phase 3 studies, the endpoint was not met. So as it stands right now, despite all these efforts expended, we don't have a new drug to add to the hypomethylating agent backbone to improve our survival. The good news is the IV decitabine has been replaced by oral decitabine, and it's based on the study called the Ascertain study. And they enrolled patients with with what we call intermediate and higher risk disease. And so that's why we can offer this to some of our patients who have lower risk disease, but are yet requiring transfusions. And it was shown in this study that it works exactly the same as intravenous decitabine. They did it very elegant kinetics, measured the effects at the DNA level, measured drug levels, and showed that the results are superimposable. So no longer need to get intravenous decitabine. Oral decitabine can replace it. And then I'm going to talk about a little bit of the findings from the National Registry, and then the clinical trials that we have going on. So just a brief history. This was founded in 2005 with a colleague, Dr. Richard Wells. We started off initially just at Sunnybrook, but then deployed it in multiple centers. We have 15 now, maybe 16 centers across Canada that are enrolling patients in this database of MDS patients. We have now in all comers about 14 years of real world data, and we're active in 9 provinces. And our objectives are many, but in addition to just understanding how MDS presents in Canada compared to other countries, what treatments are being given, how are patients doing, how long are they living, who's developing leukemia, we're also interested in 2 things: quality of life, how the disease impacts quality of life, as well as how patient-related factors impact that. We also participate in economic research. So by providing quality of life, we can sort of help with the pharmacoeconomic evaluation of new drugs, so allow the government to approve drugs, and again, see if we can replicate what clinical phase 3 studies are showing at the real world level. And we do a number of investigations. Some of you who are on the registry know that we ask you to do a physical performance test once a year, a grip strength, a stand-sit test, a 4-meter walk test. We have a number of quality of life instruments that we deploy twice a year. And then we, in the background, are recording whether or not you're needing transfusions, how often the drugs you're receiving, and how you're responding to these treatments. So we've accrued about 1,600 patients since inception, 57% from Ontario. We have now 4, maybe 5 sites going to be open in Ontario. And then we have representation, as you can see, in all these other centers around Canada. We've actually done some interesting assessments, is there differences between East and West and Central? And what we did find is that there's higher risk scores out East compared to Central and out West. We found that there's a higher rate of transfusion dependence in centrally, and a slightly higher rate of blasts. I can't see, I'm kind of blocked here by the upper bar. But we saw some subtle differences in characteristics, and some subtle differences in our patient-related factors with regards to frailty. So the patients living in BC and Alberta are the least frail and walk the fastest, which was interesting, but there's less access to lenalidomide in some provinces versus others. There's less access to erythropoietin, for example, in some provinces than others, or use of anyway. But it didn't seem to translate into a survival difference. So survival does not seem to be negatively impacted. So that was reassuring. And then I think what I'm going to do is just focus on a few of our recent publications. We did an audit of transfusions and what hemoglobin thresholds they're being transfused at, and what they wish they would be transfused at, and how transfusions impact their overall quality of life. And we did it in the United States, in Canada, and then in the UK. And what we learned is that there are differences in the thresholds. The United States is very conservative. They're often being transfused at hemoglobin thresholds of 70, whereas we're using 80 to 85 in Canada, and similar to the UK. We learned that most patients feel better after their transfusions, but not all. So even though we're improving the hemoglobin, they're not feeling better, and that there's often a one-day delay until they start feeling better. We learned that there's about a third of patients are experiencing economic hardship as a result of their transfusions. And then we also learned that about a quarter of the patients wished that they could be transfused at a higher threshold than their hematologist was currently using. And about 2/3 wanted it to be 85. We've done a prospective validation of a MDS-specific quality of life instrument called QALMS. It's now embedded in our registry. And we have compared quality of life of our MDS patients compared to published age-matched controls like population statistics. And we have shown that many patients endorse problems with limitations in their usual activities and self-care and mobility, and that compared to age-matched controls, it's worse. They have more physical limitations. Their role functioning is impaired. Emotional functioning is impaired. They endorse inferior global quality of life, and experience more fatigue. And then we've tracked it over time as well. And quality of life scores do decline, but very slowly over time. So that means that we have to do probably a better job with our therapies. But the patients who have the longest survival have the least decrement in their quality of life. And that's, I guess, kind of intuitive. When we do very careful statistical modeling about what are the factors that go into quality of life, anemia, of course, low hemoglobin is a major player. Being dependent on red cell transfusions is a major player. But for the first time, and that's by virtue of the nature of our registry, we've learned that patient-related factors are important as well, like frailty and disability. Now, sometimes patients are frail because they're anemic and transfusion dependent, but sometimes people are frail because they have a whole laundry list of health problems that make them frail. That means that getting your hemoglobin up may not fix those problems. Your bad osteoarthritis of your hip or your back that keeps you from walking and it keeps you in chronic pain may not be improved by the improvement in hemoglobin. And so we should be paying attention to those other factors if we can, and work with the primary care providers to try to improve that. We've come up with a specific MDS-specific frailty scale and showed that the frailty is independent prognostic factor of our risk scores. The one we developed is called the FS15. We've also validated a more established one called the Rockwood Frailty Scale. And what we see is that it actually adds independent prognostic value. So, for example, if you're a given risk score on the IPSS-R, if you have no frailty, your prognosis is better than what's predicted by that calculator. Whereas if you have frailty, your prognosis is worse. And it's probably not because you're at higher rate of developing leukemia, but probably because you're going to have other health problems that may truncate survival. And yeah, I'll just skip that. We've looked at ring sideroblasts. Another kind of innovation of the registry is that we should be paying as much attention to the ferritin in the iron level, but we should be paying attention to the transferrin saturation. And so a lot of my patients are very fixated on their ferritin level, but ferritin is a protein that goes up and down with inflammation. It doesn't always reflect what your total body iron stores are. The saturation is a better metric. And so if it's below 80%, your survival is not as bad as when it's above 80%. And when the initiation or following of how successful our iron chelators should be based on iron saturation. And then we have recently looked at the impact of decitabine versus azacitidine in both lower and higher risk disease, oral decitabine versus injectable azacitidine. And this is because we're trying to help get this drug approved, decitabine in Quebec. It's not approved there. And because there's never been a head-to-head comparison, and there never will be, we're trying to prove that it's just as good as azacitidine and offers the patient a hypomethylating agent that's oral and is much more convenient. And luckily, we've shown that it's non-inferior. And then finally, and we're just about to publish these results, is I don't know if anyone's been on erythropoietin and the hematologist says, no, your hemoglobin is 120, we have to reduce the dose, or we have to delay your dose because you've overshot. There's this fear from old historical data that increases your risk of blood clots and heart disease and complications like that. And we have shown in our registry that that is actually not the case. If anything, there's a hint of better survival when the hemoglobin's above 120, and it does not lead to more strokes and heart attacks. We have 3 studies going on in the registry at Odette Cancer Center. One is a randomized trial of elritercept, which is like luspatercept, but hopefully better, versus placebo in patients who have MDS, who are dependent on red blood cell transfusions, who have previously had erythropoietic stimulating agents. So the same population of medalists. And so if you're aware of anybody who has that, we would love to have you referred for this study. We have a study that's going to open very soon of a class of drug called JAK inhibitors, called momelotinib. And it's again going to be in patients that are transfusion dependent, who have had 1 prior line of therapy, which includes luspatercept. We have a wearable study, and we're very much looking for patients who are currently transfusion dependent to be on this study, where we're looking at the wearing of the Aura ring. There's a patient in the audience of mine that's wearing it right now, which is like an Apple Watch, but on your finger. You wear continuously for 12 weeks. That measures everything, all your biometrics, and we're looking at the relationship between heart rate, sleep, oxygen saturation, steps taken, physical activity to hemoglobin and quality of life and transfusions. And then for the national registry that I mentioned is open to everybody as long as you're within 12 months of diagnosis, and we welcome new patients all the time. And coming soon is this precision medicine portfolio of the National Cancer Institute called MyeloMatch, which goal is to have a clinical trial for every scenario of myeloid cancers based on specific mutations or chromosome abnormalities. I'm going to be leading the low-risk myelodysplasia MyeloMatch study. It's now going back to the FDA, hopefully for final approval, and we hope to have it open probably by the second quarter of this year, and which is now. And this is going to be a frontline study of all patients with lower risk disease who are anemic, with or without transfusions, and they're going to be randomized between luspatercept, which is not currently funded, even though we believe it's the better drug over erythropoietin, versus luspatercept combined with erythropoietin versus luspatercept and a drug called emavusertib, which inhibits inflammation in the cell, which we believe is one of the reasons for, again, low blood cell production, but also for mutations to happen. And so we're actually hoping that arm 3 may have actually disease-modifying activity, kind of similar to imetelstat. And there's going to be a higher risk study as well, probably in a year from now, of all oral therapy for higher risk disease of the oral decitabine with a kinase inhibitor called tuspetinib. And my colleague at University of Chicago is leading that study. So I want to thank you for listening, and happy to take any questions. Thank you.
Wondering if luspatercept is indicated post-HSCT for high-risk MDS with secondary poor graft function.
It's a great question. I do not believe it's been evaluated at all in the higher risk space, but it is a really good question. It turns out, though, that this sort of excessive signaling through the TGF-beta pathway is more relevant in lower risk disease than in higher risk disease. So I'm not aware of that, and it doesn't sort of biologically make sense. But certainly, it's a good question.
Thank you very much, Dr.
My
Buckstein.
pleasure.
And Dr. Kennedy will start speaking shortly, but if people... Our next presenter is Dr. James Kennedy. Dr. Kennedy is a malignant hematologist at Sunnybrook Health Science Center and assistant professor in the Faculty of Medicine at the University of Toronto. He completed the combined MD PhD program at the University of Toronto, where his graduate research focused on developing experimental models of blood cancers. Building on this background, he subsequently completed residency training in internal medicine and hematology, also in Toronto, then enrolled in a combined clinical research malignant hematology fellowship, splitting time between the Princess Margaret Cancer Center and Brigham and Women's Hospital, Harvard Medical School. His clinical focus at Sunnybrook encompasses acute leukemia, chronic myeloid malignancies, and bone marrow failure, aplastic anemia. He has developed a specialized clinic dedicated to inherited bone marrow failure syndromes in adult patients, and together with collaborators from the Hospital for Sick Children, has developed a transition of care pathway for pediatric patients with bone marrow failure. From a research standpoint, James is interested in understanding the genetic events that predispose to bone marrow failure and drive the development of blood cancers, a key step towards enabling real-time personalized therapy for these patient populations. We're pleased to have Dr. Kennedy. Thank you.
Okay. Thank you so much for having me here today. So I'm going to be talking about aplastic anemia, and in particular, a bit of focus on a certain subset of aplastic anemia patients that have inherited this. And that's something that's becoming more and more apparent now that we have the ability to do genetic testing and to find these individuals. So, okay. So what I'm going to do today is we'll start with just talking about aplastic anemia as a sort of broad group of conditions. And then we'll focus in particular on two types of aplastic anemia. The first is those who have disease driven by the immune system. And the second group is those who have an inherited cause for this. We'll talk about how we diagnose and treat the immune-mediated aplastic anemia. And then we'll finish by, I'll provide a bit of introduction to these inherited bone marrow failure syndromes, which I'm really very interested in. And, have become quite apparent as an under-recognized cause of aplastic anemia in adults. Okay, so to start, what is aplastic anemia? And I think it's important to start with what does the word aplastic mean? And I actually I didn't really know. So I looked it up the other day, and it is failure of a tissue to develop or to function normally. So in the blood system, what we're talking about here then is a failure of the bone marrow to develop or function normally. And as Dr. BUCKSTEIN said, we know that the bone marrow is the site of normal blood production. We have hematopoietic stem cells there, which divide, and then their progeny go on to differentiate and develop into various blood cell types. You recognize many of these. We have cells of the immune system like T cells or B cells. We have granulocytes or like neutrophils that fight bacterial infections. We have platelets, which are very important for stopping bleeding. And then we have red blood cells, which are important for giving us energy and powering our heart and lungs. Now, the bone marrow normally looks like this on the right. And you can see we have little bits of bone, but then in between all of that, we have lots of hematopoiesis, lots of blood cell development going on. That's what all the little purple dots are. We also have a little bit of fat. And you can see this is probably the bone marrow of someone who's about 50 years old. So we see that about half of what we see is filled up with blood cells that are developing. On the other hand, take a look on the left. The left is where we have an example of someone who has aplastic anemia. We still have, these bony trabeculi, but we can see that the bone marrow is empty. There's not all those little purple developing blood cells. Instead, it's essentially all filled up with fat. Okay, so in aplastic anemia, the bone marrow becomes empty. Now let's focus on the second word in this, which is anemia. And in fact, anemia is the wrong word for this altogether. So it's actually completely a misnomer because these patients, yes, they have anemia, but all of their blood cell types are affected. So a better name would be something like aplastic pancytopenia, or all blood cell types affected. And this is because, and this impacts how people present. So because of your anemia, you can have fatigue or shortness of breath or racing heart. Because of the low white blood cells or low neutrophils in particular, you can have infections or fevers. And because of the low platelets, you can have issues with bleeding and bruising. Okay, so what causes aplastic anemia? So, I told you that blood cell development occurs in the bone marrow, and it's all emanates from these hematopoietic stem cells. So in aplastic anemia, for one reason or another, you have low levels or low numbers of these hematopoietic stem cells. And I kind of group it into three sort of broad causes of why we have low numbers of stem cells in aplastic anemia. The first is an immune process. So that's when your body, for some reason, has turned on itself and you end up destroying those hematopoietic stem cells and you have low numbers of them. The second group, and probably the most common cause, is when the bone marrow is damaged for one reason or another. And this is, if you're receiving chemotherapy, for example, for breast cancer or something, you'll notice that your blood levels will go down. And if we look at that, if we look in the bone marrow at that particular time, we'll see that it's empty. Radiation can do the same. Certain chemicals and drugs can do it as well. And even bad infections can. The third group, and the one that I'll spend the end of the talk talking about, is that there are inherited causes of aplastic anemia. And the idea here is that you're born with a genetic change that causes some sort of interference with blood development. Okay, so how do we distinguish between these? And this is when, you come see us for the first time and we ask a million questions, okay? We want to know everything about your personal medical history. We also will ask questions about what your family's medical history are. Do you have any relatives that have had aplastic anemia or other blood conditions? We'll do a head-to-toe physical examination, and we'll do a very careful review of all medications and exposures that you've had. And the last thing we'll do is we'll very carefully look at how quickly did this develop? Did it come out of nowhere? Like 2 months ago, everything was fine, and now suddenly your blood counts are low? Or has this been something more insidious and slowly developing? Okay, so to start, for the first for the next third of the talk, what we'll do is focus on aplastic anemia that is resulting from immune destruction of blood cells. So this is quite rare. There are 2 new cases per million people per year. And about half of the individuals who develop this are actually quite young and under the age of 30. As I mentioned before, when you have immune-mediated aplastic anemia, usually there's no trigger. It just kind of comes out of nowhere. However, in a minority of cases, there can be a trigger. Some people can have a viral infection. Often hepatitis is classic for some reason. Sometimes this arises during pregnancy when there's a lot of immune things going on. And importantly, and I'll come back to this a couple times, is that the reason why it's the aplastic anemia and myelodysplastic syndrome association of Canada, the reason why they're together is because first, yes, you have low blood counts in both, but secondly, aplastic anemia, in particular this immune type, can go on to develop into MDS or to AML with the passage of time. So patients are followed with this condition very closely by hematologists throughout their life to see if that ever comes to pass. Okay, so how do we diagnose aplastic anemia? We do it by a bone marrow assessment. And as many of you probably all know, the way that we sample the bone marrow is in the pelvis. And we end up with what is very key to it is the biopsy. And that's those pictures I showed earlier. Those are little cores of the bone marrow. And that gives us a really good idea of how many cells are in there, right? That's really the key. Because aplastic anemia, you have a hypocellular or less number of blood cells in the bone marrow. It's empty. And also, we don't see any other funny business going on. We don't see the funny looking blood cells or the dysplasia that's classic for myelodysplastic syndrome, as we heard. We don't see like other things taking over the bone marrow space, like sometimes solid tumors can go there. We don't see scarring. And and one of the very important things that gets done early on is we try to figure out how severe the aplastic anemia is. And there are, formal definitions for this, okay? So we call someone as having severe aplastic anemia if less than 25% of that bone marrow space on that biopsy is filled up with blood cells, okay? And combined with that, you have to have low blood counts. And I've written something up there. Very low neutrophils, less than 0.5, very low platelets, less than 20. And, there has to be signs that your red cells aren't developing well either. And that's low reticulocytes. There's a subset of these severe aplastic anemia patients that we call very severe. And it's because they don't do as well. Their survival is less. And the reason for that is because their neutrophils are particularly low. They're less than 0.2, so extremely low. They're very susceptible to infections, and therefore there is it's a high-risk situation until we're able to remedy that neutrophil problem. And then if you don't fall in the severe or very severe groups, but you still have hypocellularity and low blood counts, we say that you have moderate aplastic anemia. And I'll come back to why I'm particularly interested in that group later in the talk. Okay, so if you have severe or very severe aplastic anemia, your bone marrow is empty, your blood counts are very low, you're at high risk for infections and bleeding. So these patients really need prompt institution of therapy. If Dr. Buckstein, Chow, or myself hear about these patients, we usually try to get them in like within a week so we can get the workup started and we can start, the appropriate supportive care while we figure out how to definitively treat them. So it is, in a sense, it's on the level of severity is almost comparable to an acute leukemia. Moderate aplastic anemia, remember, that's when, there's decreased cells in the bone marrow, but you don't have as profound cytopenias. Often, we take a step back and we monitor things initially. We want to see how fast are things changing. Sometimes these people can go on and become severe in short order. Other times, they sort of maintain at this moderate level. This patient population in particular is where a lot of these individuals actually don't have an immune-mediated process going on, but they might have one of these inherited causes for a bone marrow failure syndrome. We do eventually go on to treat patients with moderate aplastic anemia, particularly if things are getting worse, if they're starting to require transfusions, being the most common scenario. Okay, so how do we treat severe aplastic anemia? So I said, Moderate aplastic anemia, we often watch, but for severe and very severe aplastic anemia, it's important to get started on treatment right away. And fundamental to that is just supportive care. So transfusions are the backbone of what we have to give these people. They're not making their own blood, so we have to supplement their red cells and supplement their platelets through transfusions. The other thing, and I've mentioned a few times, is you're at high risk for infections. Okay, so we obviously have to treat infections right away, and your doctor will consider whether or not it's a good idea to put you on something to prevent those infections, like an antibiotic, kind of prophylactically, or even I commonly use an anti-mold or antifungal medication to prevent certain types of lung infection. The last thing is bleeding can be a real problem. And so there are medicines that we can give for the bleeding that can help minimize it. And very important, a lot of these patients are young. And in females, it's important to try to suppress menstruation so we're not losing, because the periods can be very prolonged and severe because of the lack of platelets. Okay, but none of these measures actually treat the aplastic anemia. This is just us holding the fort. So to treat aplastic anemia definitively, I'm going to talk about two methods that are used. So the first is an allogeneic stem cell transplant. So that is this idea where you're essentially, your bone marrow is empty. So what you're going to do instead is you're going to get your bone marrow replaced by stem cells from somebody else, okay, often a sibling. This is a curative therapy for aplastic anemia. And remember, it eliminates, and I haven't mentioned this yet, but in aplastic anemia, we always worry about the possibility of changing into MDS or AML. And a stem cell transplant, though it's a very involved process, is curative. It removes that possibility from ever occurring. The second way that we treat severe aplastic anemia is with immunosuppressive therapy. Remember, these are patients, the destruction of stem cells is autoimmune. So we give people medicines to calm down the immune system so that the blood system can start to redevelop. Okay, so how do you decide between these two strategies, transplant versus treating with immunosuppressive therapy? So for many years, there were fixed rules. Okay, when I was coming up and training, there were very fixed rules about who was transplanted and who wasn't. And basically, if you are young, less than 40 years of age, and if you had a donor which was a sibling who was a full match to you, okay, so like the perfect donor available, then we would treat these people with a stem cell transplant. Okay. The other scenario where we use transplant is in children. Even if they don't have a perfect sibling donor, we know that they do quite well with matched unrelated donors. So we do use that in individuals under the age of 20. You can see that this is a very small group of people, children and young people who have a perfect donor. So there's a lot of individuals who didn't fit these traditional criteria, and all those people would go on to receive immunosuppressive therapy. Okay. So what's going on in 2026? So I said, when I was coming up, the rules were very strict. There was a small group of people who would go ahead for a transplant. And the reason for that is a transplant is an extremely involved process. They start with some conditioning where, they give up in one sense, chemotherapy to try to get rid of to make space for the stem cells that are coming in. And then they give you your transplant, which is a lot like a specialized blood transfusion. And then it takes several weeks for those new blood cells to start working. And during that period, obviously, you're at really high risk of infections, bleeding. So you're admitted to hospital that entire time. And it doesn't just end after the first month. There can be complications. Now you have someone else's blood system in you. You have their immune system in you. So that can attack, you can have immune reactions against different parts of your body, leading to things like rashes or liver inflammation or lung problems. We call that graft versus host disease. So a transplant is, for good reason, we restricted it over the years to a small group of patients. However, in 2026, things are changing. We've really improved, though I'm not a transplant doctor, I give full credit to my colleagues down at Princess Margaret and elsewhere. We've made really big steps in terms of improving the outcomes of patients with transplants who have aplastic anemia. So the first thing that's happening is that we're starting to relax this very strict, you have to be less than 40 rule. We're starting to see that we can get good outcomes with select patients who are older than 40. It's important to have a transplant center that does this, and you have to select individuals who have, not a lot of additional medical problems and are, have a very good performance status. The other thing that we do is that we're starting to do in 2026 is, remember, we used to always say you only go for transplant if you have a perfect donor, like a brother or sister who is a complete match. We're starting to relax that as well and take what we call alternative donors, unrelated transplant, unrelated individuals who are a full match, or even half matches. Okay, some of your brothers and sisters are simply just half matches to you. And the reason for this is, again, the transplant doctors have made a lot of improvements in terms of their ability to find good matches and in terms of how they condition you and get you ready for the transplant. So now we're starting to use alternative donors more often in aplastic anemia. So the bottom line here is that transplant is curative for aplastic anemia. Remember, it eliminates that chance of progressing to MDS or AML, but there are risks. And for that reason, individuals who go for transplant have to be chosen very carefully. I think for everyone, the bottom line is the first thing you do when you walk into your doctor's office is you say, let's get my donor search going. Let's find out what all of my options are for transplant for aplastic anemia. And then the other thing is that if you're young, I would say under the age of 60 and healthy, you should say, I want to talk to a transplant doctor about my options. I want to see, what's available to me. What are the risks associated with transplant? How good are my donors? Okay, so we've gone from a very small group of patients who got transplants in aplastic anemia, and we're expanding that. Okay, so what's the alternative? The people who don't go for transplants, we give them what's called immunosuppressive therapy. And the idea, I think I mentioned this before, is the immune system is attacking the bone marrow. We have to chill it out. We have to calm it down so that normal blood cell development can kind of come back online. So the agents that we use are the two of them. One of them is called anti-thymocyte globulin, and the other is called cyclosporin. ATG or anti-thymocyte, this is a strange thing. It's one of the stranger kind of medicines that doctors use. So thymocytes are T cells, right? And T cells are driving the immune attack against our bone marrow in aplastic anemia. So what somebody decided to do at some point was to generate a whole bunch of antibodies against human T cells, okay? So that we could destroy human T cells. And the way they did this, strangely, was to immunize a horse with human T cells and then collect the blood or the serum from that horse and then use that to treat patients. It's wild. It works, crazy enough. It does have side effects. So you do have to come into the hospital, okay? And as you'd imagine, getting some sort of horse serum, you can have a lot of reactions while you're getting that over your 4 days. You can get rashes, blood pressure issues, even very serious allergic reactions. So it's an effective therapy. It really wipes out T cells, but it does require you to be in hospital. The thing so you get this ATG for 4 days, and then we put you on a pill medicine called cyclosporin, and it too messes up with, it settles down your T cells. So it's interfering with the production of those blood cytokines that are required for T cells to divide. And so You get your ATG for 4 days, and then generally you continue the cyclosporin for 6 to 12 months, and then you slowly taper that off. Okay. And so there's two things that are challenging with this. The first is that not everyone responds. Only 2 out of every 3 people do. And the other thing is these responses take time. They can take up to 6 months. And so, that during that entire period, your blood counts are low, you're getting lots of transfusions, you're susceptible for infection. So it's really, you can see how this too, is a very challenging therapy to go through, and it is a challenging therapy to go through. Okay. So for many years, similar to MDS, we were saying, okay, can we improve upon what we have? And in a sense, similar to MDS, there wasn't a lot of progress. Okay, we give this horse serum and cyclosporin, and we wanted to see if we add additional things to it, does it work better? So the first thing we did is we tried to add growth factors that stimulate white blood cells, right? We want to get more white blood cells faster. Unfortunately, that didn't work and may have even increased the rates of progression to MDS or AML. Then we said, okay, we've got the immune system down. What if we push it down even lower? That didn't work either. We added on a lot of the drugs that kind of rheumatologists use to calm down the immune system. And, those didn't help or improve the response rates either. But some good news, finally, some progress in the 2020s. So there's this new medicine called L-Trombopag. And what this is its technical name is a thrombopoietin agonist. So what is thrombopoietin? It is a cytokine that stimulates blood cell development, and it most famously stimulates platelets, okay? But it also can lead to the expansion of, remember, those valuable hematopoietic stem cells that you're lacking in aplastic anemia. So it's sort of been repurposed from being a platelet drug to being an aplastic anemia drug. And there was a trial that was done in 2022 where they took people, they had 2 groups. The yellow group, you got horse serum with cyclosporin, and the other group got the horse serum, cyclosporin, and this new drug called L-Trombopag. They would continue it for a period of 6 months. And we saw that the outcomes were better in the blue group, the group that got the L-Trombopag. We see that at 3 months, having a complete response in terms of improvements in your blood counts, rates were 10% with the traditional way and up to 22% when we added this additional medication. And I think the most important thing about this medicine is that responses occur a lot faster. Again, it takes months with the traditional approach, and you can get down to a median or a middle of about 3 months when you add this additional agent. And to me, that's where the value is that you can get the responses quicker and faster. Okay, there's less of a period where your blood cells are low, you're getting lots of transfusions, you're requiring, you're at risk for infections. Now, as Cindy probably knows, this medication, however, is not funded currently in Ontario, or I don't believe anywhere in Canada. So what do we do about this? Well, we do interrogate for everyone. We look to see if they have drug insurance that could potentially cover this agent. The other thing that I do, and I learned this from Dr. BUCKSTEIN, is at about 3 months, if we're not seeing, a robust response by that point, we can make an application to get the drug compassionately. So out of the goodwill of the drug company. They won't give it upfront, but they will give it a number of months later. We have to keep pushing to try to get this drug available for aplastic anemia patients so that they can get faster responses. Okay. All right. And lastly, how do we treat immune aplastic anemia in older people? So I've mentioned 2 types of therapy, both of which, have toxicity associated with them, the transplants and the horse serum one. In older people, this is a challenge to do either of these things because these are intensive therapies and they're reliant on you having excellent heart, lungs, and kidneys. And not everyone will have that once they become a bit older. So the approach to older patients is first, we take stock of what's important to you. And, most people we will give them the transfusions, the antibiotics, and then we use sort of single agents. Instead of using the combinations of things, we can use cyclosporin alone if your kidney is okay. We can use L-trombopag alone. Again, a little difficult to get, but we have been able to get it. And the other thing we can do is give anabolic steroids, which stimulate, again, it's another agent that drives you to make more hematopoietic stem cells. Okay. So now I'm going to shift gear. We've talked about immune-mediated aplastic anemia, which really is, what a lot of doctors have traditionally and patients have thought aplastic anemia was this autoimmune condition. And what I'm here to spend the rest of the time today talking about is that there's actually, this other group that we always thought was really, really rare that has an inherited cause. In other words, they're born with a genetic change that interferes with blood development and leads to aplastic anemia. Okay, so these are called inherited bone marrow failure syndromes. This is a nightmare for sort of hematology trainees. There's a long list of like 50 to 100 of these things. And patients present, in a common sort of way. They can have low blood counts. They can have bone marrows that are often kind of empty. And we know that they can go on to potentially develop MDS or acute myeloid leukemia. But they also have other stuff going on. This is something they were born with. There's a genetic change in all cells in their body. So you can get non-hematologic manifestations. So you can be born with congenital malformations. You can have other organs that are involved. You can have higher risks of other cancers. So you can see, like, historically, this was the realm of pediatric hematologists, right? Kiddos born, they may have blood problems right from the get-go. They might have some congenital malformations. But what has changed in the last, I'd say, 5 to 10 years is that we know that we can find these conditions in adults if we look for them. It's not always this. What we were finding before was just the tip of the iceberg, those who would present in, when they were, in first 10 years of life, very, overt presentations. We now know that adults can present much more subtly, maybe with just like one of these things going on. And the other thing that we've learned is that even though we thought these were all zebras, right? Really rare conditions. And individually, they are rare conditions, but collectively, they're actually pretty common if you're looking in the right group of people. So if you look at young MDS patients, less than 40 years of age, about 20% of those patients, the reason they have MDS is that they have an inherited bone marrow failure cause for it. The other thing is if you look at young aplastic anemia patients, again, about 10% of those have an inherited cause for it. So this is new. You can see these papers are just in the 2020s. This is something that we didn't look for 10 years ago. And now that we're looking for it, we're starting to see the whole iceberg, not just the tip. So what are the clues to one of these inherited bone marrow failure syndromes? Well, the first is often you start to see changes at a young age. This is why I said when I first see patients, I look at over time, how have their blood counts behaved? Okay. Often in this scenario, you'll see blood count changes starting at a young age and then slowly creeping and changing over the years. I mentioned that moderate aplastic anemia or slight hypocellularity is pretty common. And then there's the other things I mentioned. You can have congenital malformations. You can have other organs involved. You can have a family history. And I'm currently working with a family where there's 2 brothers with low blood counts. There was a father who had aplastic anemia and a grandfather who had leukemia. So that's the sort of pattern that we can see when you're dealing with an inherited bone marrow failure syndrome. Okay, so now we get into the nitty gritty. So as I said, there's probably about 50 different inherited bone marrow failure syndromes. A subset of those present as aplastic anemia. And really, I've listed a few of them here. They're mostly impronounceable, but there's sort of 2 that I would want to focus on because they're more common, okay? The first is something called Fanconi anemia. So Fanconi anemia, again, this is a condition where you have mutations that impact your ability to repair DNA. As Dr. Buckstein said, as we get older, through environmental exposures and aging, we make mistakes when we're replicating our DNA. And it's very important that our body repair those mistakes. If you have an inability to repair those mistakes, it can lead to issues like aplastic anemia and Fanconi's anemia. So again, one reason why this is a challenging condition is that there's not just one gene that causes Fanconi anemia. There's actually 22 different genes involved in DNA repair. And we've named them after the alphabet. And they go from A to W now. So it's a big, big group of genes. And you may have heard of some of them in a different context. So the BRCA genes or BRCA genes that are associated with risk for breast cancer or ovarian cancer, those are actually Fanconi anemia genes. If you inherit one defective copy of a BRCA gene, then you're at risk for breast and ovarian cancer. If you inherit two, one from mom and one from dad, then you not only have that risk of solid cancers, but you have Fanconi anemia. You have the bone marrow failure syndrome. Okay. All right. So how does Fanconi anemia present? From a hematology standpoint, it presents as an aplastic anemia. Okay. Testing for Fanconi anemia should be done on all young patients with aplastic anemia. And as I said, there is a risk for turning into MDS or AML. 30% of patients by the age of 50 turn into those more serious conditions. As occurs, because the Fanconi defect is throughout your entire body, there can be other changes that you see. So you can have congenital anomalies. People have short stature. They can have developmental delay. They can have skin changes like these, what's called cafe au lait spots, which are pigmented and kind of look like coffee. It's very common to have issues with your thumbs. And then lastly, and other organ systems can be involved too. And plus, it's not just the blood system that's a problem here. We're not repairing our DNA. So you're at risk of other solid tumors as well. So you can see there's risk of various solid tumors higher than the general population. So how do we diagnose Fanconi anemia? So remember, it's a DNA repair problem. So we actually test for that. We test for the ability, we test for chromosomal fragility, okay? We take blood, we expose it to some chemotherapy, and we look to see how much problems it causes. Okay, so this is the test that we do. We take blood, we expose it to different chemotherapies, and then we look at the karyotype. And normally, I don't know if you've seen karyotypes before, it's all very nicely organized. There's a whole bunch of different things going on here. There are breaks, there are these radial structures, all these different sorts of things that are occurring because after we exposed the cell to chemotherapy, because of the Fanconi anemia defects, we weren't able to repair the DNA. Okay. So the first thing you do is we do this test looking for fragility or sensitivity to chemotherapy. The second thing we do is genetic testing, okay? And it's a specialized process, okay? This isn't something that you can just order and get done, at the local life labs. We actually have to send the testing out of country to get this done. And the other thing that's tricky with this is that, Dr. Buckstein talked about genetic testing becoming available for MDS patients. And that is true, but the panels that we're using in Ontario at this point in time don't include the genes for Fanconi anemia. Okay, so that's why we need to send them out of the country. The other thing that makes this a bit of a hurdle and why we traditionally weren't finding these patients is because, it's easy to do a genetic test off blood, right? You just poke someone, take their blood, or less easy, less enjoyable to do it off of bone marrow, right? But, relatively accessible. In these genetic conditions, we have to prove that the defect is everywhere throughout the body, right? It's not just in the blood. It's not just something acquired in the blood like you would see in MDS. So we actually have to do genetic testing. What we do is we do it on the skin. So we take a little skin biopsy, we isolate cells from the skin cells, and then we do our DNA testing on that. Now, there are other ways. So this is the way we currently do it at Sunnybrook, and they do the same at Princess Margaret's. We take a little piece of the skin. there are alternative sources for this. We call it germline DNA. That means, all throughout the body. You can, we can use hair follicles. And then the other thing that they're actually doing in Nova Scotia right now with one of my colleagues is working on using nail clipping. So they leave you in a room to cut your nails, and then you give all your nails in a little thing, and we isolate DNA from that. And then it seems a lot easier than this skin business, but it does take a lot of like lab infrastructure to be able to like crush up the little fingernails and isolate the DNA and stuff. So you can see that this takes some infrastructure around it to get the testing done. And as Cindy probably knows, the infrastructure doesn't really exist. And that's one well in Canada. And that's one reason why, these patients have not been traditionally recognized that often. Okay, how do we manage Fanconi anemia? I'm not going to go into too much detail. I think the bottom line is that it is a team effort. If there's one, to manage these conditions, you need lots of different people involved. Hematology, that's me. You need a bone marrow transplant doctor. You need genetics involved. If you have the thumb problems, you might need plastic surgery. With the skin issues, you might need a dermatologist, et cetera. And the main thing that I'm doing as a hematologist in these patients is I'm watching them very carefully because their blood counts can get worse. The cytopenias, the low blood counts can progress to the point of needing transfusions. And remember, there's a high risk of changing into MDS or AML. My job is to find that soon, to find it fast. As soon as there's the first sign of either severe bone marrow failure or MDS or AML, we want to take action and transplant these people. Okay, so how do we treat them? One method is transplants. And the other thing is, coming up again for the second time, you can use things like testosterone derivatives to stimulate hematopoietic stem cells. And again, a big part of what I do when I see these patients is monitor them for all the non-blood related manifestations that can make sure I connect them with the dermatologist and a gynecologist, et cetera. So it's really a team effort to take care of these patients. Okay. Let's talk about the second one of these inherited bone marrow failure syndromes, and it's called dyskeratosis congenita, or a telomere biology disorder. Dr. BUCKSTEIN mentioned telomeres. She already did the hard lifting for me here. So telomeres are the plastic caps on the end of shoelaces, right? They're protecting our chromosomes. They're on the end of our chromosomes like they show here. And there's a whole bunch of proteins in the body that create a complex whose job is to maintain these telomeres, right? First thing is it's important. We don't want them to get too short, right? If they get too short, then you can develop blood and other problems. So we have this whole complex of like 15, 20 different proteins whose job is to maintain the end of the shoelace. So then there are, what these conditions are, what the condition I'm talking about is, dyskeratosis congenita, is that you have disrupted that complex, that telomerase complex, whose job it is to maintain the shoelace. And what happens then is that the telomeres get too short and too fast. Okay. And again, the genetics here are quite complicated. There are many, remember, there's all these different proteins that make the complex. There's a whole series of different genes that are inherited different ways that can be mutated and cause this condition, dyskeratosis congenita. And the point of this on the left is just to show that different genes can lead to presentations at different times in people's lives. There are certain genes like this one gene that is excellent, meaning that it affects boys predominantly. It's one of the more common ones, about a quarter of patients. It presents in pediatric realm, right? It's the tip of the iceberg, okay? But there's a whole series of genes that lead to presentations later in life. And this is what we never recognized before. This is the body of the iceberg that's underneath, that's underneath the waterline. And in patients who have that pediatric type of dyskeratosis congenita, they have, before genetic testing, clinicians had to rely on like their eyes, right, when they examined patients. And they found that there was a group of patients who would have these characteristic skin and nail findings, a rash across their chest, fingernails that were that were dystrophic. And we even have sometimes precancers inside their mouth, something we call leukoplakia. This is how patients with dyskeratosis congenita were identified for years, was just on this triad. So I probably have 30 to 40 patients with this condition in my clinic. I have one who has this triad. So it goes to show again that what we used to think was going on was the tip of the iceberg. There's a whole lot more going on below the surface. So we talked about how it's important to maintain the shoelaces, right? So if you don't maintain the shoelaces, you develop, I'm a hematologist, you develop blood problems, you develop aplastic anemia, there's a risk of going on to MDS or to AML. But there's all these other organ systems that can be affected. The liver is in particular, people can get cirrhosis of their liver. People can get fibrosis of their lungs. They can have bone issues. It's really, you can see, it's just the whole body can be affected by something like this. And the hematology is just one piece of it. Okay, how do we diagnose telomere disorders? So the idea is we have to measure the size of the cap on the end of the shoelace. And the way we do that is we basically kind of use a special probe that binds to that cap and allows us to quantify how much of the cap is present or not. Interestingly, as everyone ages, their telomeres, these caps on the end of chromosomes, get shorter. So this is showing percentiles, okay? So this is the first percentile, this is the 99th percentile. So 99% of people, their telomere lengths will be between the red and the blue lines. And you can see as people get older, their telomeres get a little bit shorter. So this is a person who has normal telomeres around the 30th percentile. The dot, the test that I did falls right in the middle. On the other hand, you can see that this patient has telomeres that are well below the first percentile. And this is how these patients with dyskeratosis congenita can present. Okay, and so first step, if you suspect one of these disorders, is we measure the telomere lengths, okay? The second step, exactly like Fanconi anemia, is to do this specialized genetic testing. Again, not available on the routine panels that we have in Ontario. We have to send it out of country right now. We're working on it right now. There's initiatives to get this testing available in Ontario, and it should be available at some point in the near future. And again, the issue is we can't just test the blood or the bone marrow. We have to test another tissue like the skin. Okay, how do we manage these conditions? Again, teamwork, right? All these different body systems can be affected. So we need to involve hematology, transplants, genetics, lung doctors, liver doctors. I'm on, as I'll mention, we now are creating a group of physicians in Toronto who see these conditions, and we spend a lot of time talking to each other and collaborating to manage people who have these telomere disorders. Again, similar to Fanconi anemia, from a blood standpoint, the issue is the low blood counts and the risk of going on to develop MDS or AML. And so what I often do in these people is we monitor them very carefully. We do bone marrows once a year, okay, to look to see what changes are happening, what genetic alterations are kind of accumulating over time. And again, the treatments, I won't spend too much time, but if someone has severe aplastic anemia or develops MDS or AML, we would do a transplant in these individuals. And if they're not going for transplant, we can sometimes, yet again, third time today, improve things with like anabolic steroids or testosterone derivatives. Interestingly, there's some early evidence that the testosterone derivatives could actually maybe prevent the telomeres, those caps, from shortening it. It's a little bit controversial, but some people believe that they can extend those telomeres. And therefore, these drugs might not only be good for the blood system, but also for the other organs throughout the body. Okay, and again, very important to involve a multidisciplinary team and to regular assess these patients for the other non-blood manifestations like the liver, the lungs, the skin, etc. Okay, coming to the end. So what I've discussed today, that aplastic anemia is like a blanket term, right? People have low blood counts and they have a bone marrow that looks empty. Many of these patients, it's because their immune system has attacked their bone marrow and has emptied it out. but there are individuals who can have these rare inherited causes. And as you can, this is what I'm really interested in, is this, the whole iceberg. In terms of the immune-mediated aplastic anemia, we talked about the two major types of treatments. If you're young and healthy with a great donor, you would go for a transplant. The alternative is the immunosuppressive therapy with the horse serum and cyclosporin, and hopefully coming soon, eltrombopag. And then I highlighted that things are changing in 2026. We're starting to see better outcomes with transplant. So we're starting to use it in patient populations that we didn't before, older patients and individuals who don't have the perfect match donor. And then I finished today by talking about these rare zebras, the inherited bone marrow failure syndromes, that we suspect in people who don't have severe aplastic anemia, more of like a chronic moderate aplastic anemia picture. They may have a family history of blood issues. They might have non-hematopoietic manifestations. We diagnose this with specialized genetic testing, and the management is complex and multidisciplinary. And for that reason, it's really important to have specialized clinics in this area. And that's really, now comes the service announcement. So what we've done at Sunnybrook is we've established, in Toronto, the first adult bone marrow failure clinic where we specialize in these inherited causes of aplastic anemia. So it's a huge team effort. I work very closely with a physician assistant. We have collaborators from genetics and pathology, as well as collaborators from across the city. So remember, this is a lot of these conditions. Who has the most expertise in these are the pediatric doctors. So I work very closely with the pediatric bone marrow failure specialist at Sick Kids, Dr. Dror. We've connected with a transplanter at Princess Margaret so that we're all talking to each other in the same room. And then, I also work closely with a doctor at St. Michael's who specializes in inherited bleeding disorders. So our objectives with this has been to first get a workflow in place so we can test people for these conditions, right? It's been a major barrier. 5 years ago, people would just say, oh, it's too much work. I don't know how to make this happen. It's too, but what we've done, and I'll talk about it a bit, is develop a workflow so we can actually investigate people for the whole iceberg of these inherited causes. The second thing we've done is developed a transition of care framework between the Hospital for Sick Children. Remember, a lot of these conditions are diagnosed in pediatrics, and now these patients have a home. They'll come to our clinic. And then the last thing is, as always is important, as you can see from Dr. Buckstein's MDS registry, you start and something grows over time, right? You get more patients, you do more research, and you get more collaborators. So that's what our sort of long-term goal here is. So first, this workflow. We now are able to, at Sunnybrook, do these skin biopsies that I talked about. We get the skin cells cultured, we extract the DNA, and we know how to get the testing done out of the country. I wouldn't say it's seamless, but we have mechanisms in place now that make this possible for any patient that I see. And the word has got out to some extent. So now, we've become a referral center for working up adults with either a suspicion or confirmed bone marrow failure syndrome. So right now we have 85 patients, which is actually, if you consider how rare we thought these disorders were, this is a remarkably high number. And I get patients as a second opinion from other hematologists. I get some from the genetic service. They'll find someone with a mutation and send them over. And as I mentioned, some of them come from Sick Kids. So the Sick Kids piece of things. So as I said, we often find these conditions in childhood, and they're managed in very special clinics at Sick Kids, where they have this multidisciplinary thing all sorted out, and they've been doing it for years. So you can imagine how challenging it is to move from the pediatric hospital to an adult hospital, where there's many, many more patients. There's less staff around, there's less support. And so traditionally, this is a super stressful period for the patients and their families. And also these people are 18, 19 years old. They're finishing high school. They're going to university. It's actually a really volatile time in their lives. And you can imagine a lot of people just fell off the track at that point and got lost to follow-up, and all the important screening that they do and kind of doesn't get done as it should. So adult inherited bone marrow failure clinics have been historically an unmet clinical need. And so we've set up this collaboration with Sick Kids. It's been going now for since late December 2023, and we've had 26 transfer of patients yet. So these are not particularly common conditions, but you can see they add up over the years. We're seeing about 10 patients per year now, building our expertise and our infrastructure. We do a lot of effort to try to, teenagers are challenging, but there's a lot of effort to sort of keep them on track. We have this specialized physician assistant who will email them, who will work on making sure appointments occur at times when they don't have exams or during summer breaks. You can see how that's additional infrastructure that just historically hasn't been present in adult centers, right? You guys have tried calling in to change your appointment times. It's a disaster, right? So you can imagine if you're balancing everything that goes with being 18, 19 years old and trying to move your appointments around. So we're trying to make things much more flexible. And our attrition rates, I can think of these 26, there's only one that I haven't been able to track down recently. So that's really, really quite good. The last thing that we're trying to do is to foster expertise, collaboration, and research. So as I mentioned, we now meet as a city group who's interested in this area, where we have pediatric hematologists, adult hematologists, transplanters, and genetics all together to discuss these cases, to put our experience together. And, compared to Dr. BUCKSTEIN's thing, we don't have as much yet, but we're starting to grow, right? So we are publishing, we're doing research in this area. And in fact, we've established a protocol for treating AML that arises in the setting of these inherited bone marrow failure syndromes. You can't use the standard ways of treating MDS or AML. You have to do something lighter. And then we're rolling that out now and using it as well at Princess Margaret Hospital. We've started biobanking, which is where we store biological specimens for patients so we can do further research. And we're also going to be opening the Canadian Inherited Marrow Failure Registry so that we can have a big group of patients that we can study with these conditions. Okay. And that's all I wanted to say. So hopefully today we talked about aplastic anemia, focused on the immune type of aplastic anemia, but also hopefully I introduced the idea that, there is a whole group of patients that were under-recognized, that we thought were only in the pediatric realm, but we're finding in adult hematology centers, and that we're working towards providing good multidisciplinary care for them. Thanks.
The first one is, how does ultraviolet increase red blood cells, the mechanism, and does it affect neutrophils?
So yes, we originally thought it would just be good for making more platelets, okay? Because thrombopoietin is on megakaryocytes, the cells that make platelets, and it is very good at making platelets. But the stem cells, the apex of that hematopoietic system, they have thrombopoietin on their surface too. So it works more slowly, but we expand our stem cells, and that can allow us to have responses in the blood counts in all of the lineages. So red cells, yes. Neutrophils, yes. And platelets, yes. Okay, it's by acting on the stem cell. Yeah, so yeah, it is. And I'm not a transplant. I'm not the best person, but I'll tell you what I've heard. One of the challenges with doing a bone marrow transplant in an adult is that we're big and we need a lot of stem cells to repopulate the bone marrow. Okay. And generally from the umbilical cord, that we take up, there is not enough stem cells to repopulate an adult. So, there have been initiatives, in Quebec, I know they've been working on expanding stem cells. In Vancouver, they were at one point doing some umbilical cord transplants. We don't do them routinely in Toronto. Yeah, it's the same. Yeah. So what they do is they for some reason at that point in time, they take the blood out of the placenta or out of the umbilical cord. It's full of stem cells. It's full of stem cells, but not enough, unfortunately, for most adult indications.
Would it work on a child that it's from? Like if one of the kids from my sister, let's say, got sick, can they use those?
Generally not. Okay. And I'll say generally because, let's say you get a transplant for MDS, okay? one of the purposes of that transplant is to rebuild the blood system, right? You know, get a new blood system. But the other point is an immune thing. So you now have someone else's immune system. It will attack any leukemia or MDS that remains and destroy it. So you can see if you're using your own blood cells, you don't necessarily get that immune effect. So particularly in conditions like leukemia, we wouldn't necessarily want to do that. We'd always want somebody else's. So we have that immune effect.
There's another question, it might be a loaded one.
Uh-oh.
How will AI help developing a new treatment trial on AA?
How will AI help? That's a good question. I think trials, you know, when I was watching Dr. Buckstein present, and, you know, in MDS, a relatively rare disorder, there have been a whole series of trials, right? In aplastic anemia, a rarer condition, there are not as many clinical trials, right? That L-Trombopag trial was that I mentioned is really one of the few ones that's come out. There's a lot of retrospective stuff where you get a bunch of patients together and analyze them, but much more difficult to run trials in aplastic anemia compared to an already hard MDS, which is hard enough in itself. You know, I think that in terms of aplastic anemia, I think that we need to continue to look for add-ons or additional therapies that we can add to immunosuppressive therapy. You know, and we can use AI to, you know, potentially identify like new targets. You know, in the lab, when I used to work in the lab, you know, we can analyze cells from patients, find potential pathways that could be used to expand stem cells. That's really what we need to do. So, you know, I think we're using a lot of these machine learning techniques to analyze sort of the whole genome in patients. So using those techniques to identify things that can allow us to expand stem cells is a good place to go. You know, there's exciting in the inherited bone marrow failure world. There's, you know, they're starting to have, remember, in a genetic disorder, the way you can fix it is by fixing the gene. So they're actually doing gene therapy now in a minority of cases for Fanconi anemia or the disc keratosis congenita. Early stuff, but very, very exciting because that too would be a cure. Like, I talked a lot about the first line setting, right? So what you do initially. So you would have gotten the horse serum and cyclosporin initially. And because you did not have a perfect match donor, they probably said no transplants now, right? Or age. There you go. Or age. There you go. But then you went through multiple lines of treatment. Yes. And then they're like, that's when, and this is where we're really starting to use transplants a lot more liberally, is, you know, in, you know, 20 years ago, a 9 out of 10, they would have been very afraid of doing that. But now we're able to do those sorts of things. And so, yeah, there's excellent doctors at all the, you know, there's usually at the big cancer centers, there's usually, you know, they all have expertise in this area. And even there's doctors in Hamilton that I know who are interested in these inherited conditions as well. So we're starting to build, like, you know, we're working together, you know, not against each other, but it is, that's, I'm glad the transplants worked well. That's good. Which, you know, for a patient with aplastic anemia, as the doctors probably would have told you, is on the older end of things. You know, is, again, traditionally they would have said too old. But when you make it through these other lines of treatment and they're not working or you're having side effects. So with the immunosuppressive therapy, again, you know, not everyone responds, about 2 out of 3 people, and about 1 out of 3 people who do respond, it can come back. You know, and that's when we look at the rabbit, sometimes the rabbit serum, or nowadays we would look to transplants in that setting.